Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. It's December 10th, 2025, and ASH 2025 has wrapped up. Wasn't there? We've got a publication, a couple abstracts, a lot of talk to discuss, so let's get right into Majestic 3. This was a public or a presentation at ASH. This is one of the late-breaking abstracts, if I remember correctly, but was also a simultaneous publication in EJM. So this is the most complete data we have of everything we're going to talk about today. This is from Luciano Costa, who is at UAB in Birmingham, but also was an attending physician at MUSC when I trained there, rounded with Dr. Costa. Certainly a wonderful physician. This is Teclistamab, Teclistamab plus Daratumumab in relapsed refractory multiple myeloma. Big study. So we're going to break this down in a little bit of detail. So these were patients that were relapsed refractory, 1 to 3 prior lines of treatment. They had to have had, a proteasome inhibitor and lenalidomide, and had to be, relapsed or refractory to their, to lenalidomide at least. And that means they had to have either progressed on lenalidomide, say they're on maintenance lenalidomide, they have progression, or they progress within 60 days of stopping lenalidomide. And they're randomized to either POM, Dara, Dex, or Bortezomib, Dara, Dex. This Bortezomib, Dara, Dex arm was the same control arm in the recent approval, the reapproval of belantamab mafodotin. So, it's a reasonable comparison. It's a good comparison arm. They all got Dara in the control arm because only 5% were Dara or CD38 monoclonal antibody exposed initially. So good control arm, and of course, if you were refractory to an IMiD or to POM, you couldn't get the POM arm. If you were refractory to Velcade, you couldn't get the Velcade arm. So good design study here. There's a lot to go through with this to talk about, and the big take-home points here, just so you know where we're going. One, much better compared to kind of standard, let's call it second-line therapy, although in some cases it's third or fourth-line therapy for these folks with multiple myeloma with Tecdara. Huge 3-year estimated PFS improvement, 83% versus 30%. Huge improvement in progression-free survival, but there definitely is an infection safety signal here. In fact, we'll get into this, but deaths from adverse events incurred in 7.1% of people with Tecdara. To put that in perspective, let's say you had a patient you want to take to auto transplant with myeloma, and you said, there's a 7% chance, 5% chance of non-relapse mortality with this. Would you pursue auto transplant? And I think, a lot of people recently might say, no, that's pretty toxic. Now, there's some things that they did in the middle of the study to mitigate that, which we'll get into. But that's one thing to think about here is there's even in all the people tweeting and talking about this, they're all saying infectious complications need to be worried about. We got to work at that. And usually, all of our treatments have infectious complications as a risk. And if they're saying that, it tells you there's definitely something to this with Tecdara. All right, so why Tecdara? All right, Teclistamab and Daratumumab. So they have this in their background here. I'm quoting here. In addition to direct on-tumor effects, Daratumumab sensitizes the immune microenvironment by depleting immunosuppressive T cells and enhancing CD8 positive T cell cytotoxicity, which you need for really Teclistamab to work. You need those CD8 positive cytotoxic T cells. And they have a reference here. You go back and it's preclinical data where they're looking at some myeloma cell lines, but also bone marrow samples of people with myeloma or plasma cell. So there's a lot of good preclinical activity that this combination could be better than just additive, that it could be synergistic. All right. So that's the rationale. It's not just, hey, let's add 2 drugs that are good and add them together. There's some rationale for these 2 modalities together as a BCMA bispecific. And the CD38 targeting antibody in Daratumumab. So again, that'd be 1 to 3 prior lines of treatment with all the kind of the standard lines, but not Dara. They could not have received prior BCMA targeted therapy, and they cannot be refractory to anti-CD38 antibodies. So these were not folks on Dara maintenance who then progressed on DARA maintenance. There were only 5% who had like a CD30 antibody. They could not have been on that recently. Otherwise, they would have been refractory to that. Okay, so that's what they did here. Let's talk about patients first before we get into some of what they did, which is the details matter here. So it's about a little under 600 people on the study, 290-ish in each arm. 65% white, 22% Asian, 5 to 6% black. Pretty reasonable representation there by race or ethnicity. 40% were ECOG 1. I think that's pretty indicative of the myeloma patient population. The median age was 64. Reasonable, maybe a little bit younger. You do have some folks as young as 25 on this study. So keep that in mind as you try to extrapolate this to your 70 and 80-year-olds with myeloma in clinic. And most of these folks, the median time from diagnosis to randomization was 3.8 years. Median number of lines of prior treatment was 2. And again, I've said this before, only 5% had prior exposure to a CD38 monoclonal antibody. Okay, so they're getting basically standard Daratumumab here. And the Dara-Pom-Dex, Bortezomib-Dex, Dara, those are the standard doses. They do the ramp up of Teclistamab, then 1.5 mg per kg weekly for cycle 2, okay? Then 3 mg per kg every 2 weeks for cycles 3 to 6. That is a higher dose than is FDA labeled, which is 1.5 mg per kg every 2 weeks. And then after cycle 6, they do 3 mg per kg every 4 weeks, which is pharmacokinetically, they say, equivalent to 1.5 mg per kg every 2 weeks. But for cycles 3 to 6, for those those 4 cycles after cycle 2, they're getting twice as much Teclistamab. Okay, they do note that they did allow dose reductions from 3 to 1.5 mg per kg, or from, say, doing treatment every 2 weeks to every 4 weeks. They were permitted by sponsor approval. Okay, now that's notable here. All right, so now we got to talk about some of the stuff that no one mentioned on X about this study. Now, this is not in the paper. This is not in the supplement. It's in the protocol. The original protocol for this study had an arm where they gave a fixed dose Teclistamab of either, let's say, 100 milligrams, 200 milligrams, 300 milligrams based on where you are in the step up and your weight. And there was, of the first 31 people, I don't know if it's the first, but of 31 people on, I think it's the first 31, 8 of them died. 26% mortality rate with the fixed dose Teclistamab. And that was before they did not have stringent criteria for monitoring for hypogammaglobulinemia and IVIG supplementation, which was corrected. And since then, they say, the rate of infections was much better. In fact, they had 12 people died on the study before they added this IVIG protocol change to 2 people afterwards. So that was a lot of it, but some of it was also fixed dosing, where we're not doing weight-based dosing. And these fixed doses were higher than the milligram per kilogram dosing would have been. Okay, so it's hard to know how much of those early mortality deaths from infection were giving more Teclistamab, or not stringently looking for IgG levels less than 400 every month and giving them IVIG if it's below that, which is kind of standard practice. We know these drugs cause hypogammaglobulinemia. Plasma cells, whether they're malignant, like myeloma, or non-malignant, they're making antibodies. And if we're killing myeloma cells, we're killing healthy plasma cells, we're not going to be able to make these antibodies. So that kind of makes sense that we need to be doing that. And that's a big takeaway point from this. The other takeaway point from this, and perhaps with ASH, is, we don't have dose reductions that I can see in the label for Teclistamab. Either hold it till the toxicity resolves, and then you restart. They did allow some dose reductions here. Now, from 3 to 1.5. Again, 3 is a higher dose than is in the label. And then also decreasing the dosing frequency. There are two abstracts at ASH, both from Mexico. One called Teclisto, where they're actually doing lower doses and seeing good responses. Now, this is about 35 patients or so total. But I think it makes sense conceptually that we need to question the dogma that we don't dose reduce monoclonal antibodies. Especially some of these are probably dose-dependent toxicities, and we need to rethink that. Okay, so back to the design of the study. There, we talked about the Teclistamab. They did pre-medicate with Dex for the first 2 weeks, but then no subsequent Dex was required. Also important for patient safety and tolerability and that infectious risk. So infection prophylaxis included IVIG supplementation. There was a protocol change to institute that in February of 2023. Prophylaxis for PJP, herpes, zoster reactivation. These were all given according to institutional guidelines, they say. All right, so our primary endpoint here is progression-free survival. They wanted 560 patients to have a 90% power to detect a 30% improvement in PFS. They showed much more than a 30% improvement in PFS, and they got more than 560 patients. Okay, so let's talk about our results here. All right, so our progression-free survival, I've already mentioned the top-line result here, 36-month progression-free survival. This was exciting when the abstract was published, 83.4% versus 29.7%. That is a hazard ratio of 0.17 with a 95% confidence interval, 0.12 to 0.23. Very large effect size, very small 95% confidence interval. Overwhelmingly positive study for progression-free survival in patients who did not get DARA up front in 95% of the case. So maybe not the patients you're seeing right now in myeloma when you think about how we're going to implement this. If you look at our subgroup analysis, by the way, this progression-free survival curve is flat. Like if you did a plank right now, your back could not be as flat doing the plank as this PFS curve is. If you just eyeball it, right? So the 36-month PFS is like 83.4%. The 24-month looks like 85%. The 9-month looks like 90%. I mean, it is, really, really impressive. And when we look at our MRD negative rates here, to get ahead of myself here, it's 58.4% with Tec-Dara versus 17% with the control arm. We know from the CARTITUDE-1 data that maybe a third of people with ide-cel, so a BCMA targeting CAR-T product, a third are MRD negative without treatment 5 years later. That's one thing people are going to have to look at for a follow-up here is, are we seeing durable responses in people? Could we stop treatment in some of these folks, especially with some of the infectious complications that we see here? I will point out, only 31 people had prior CD38 therapy in the study. They seemed to benefit just as well as those who had not had it. Again, they weren't CD38 refractory, so it had been a while since they'd had that. Overwhelmingly, people are getting Dara-Pomdex. They're not going back to the proteasome inhibitor. There is a little bit of a signal here that this is a little bit more effective in the younger patients. So this is kind of what I do in subgroup analyses. These are all hypothesis generating, hypothesis forming. But we have 3 cohorts here, less than 65, 65 to 75, greater than 75. And our point estimate for PFS going from less than 65 on up is 0.13 to 0.17 to 0.35. All of them are overwhelmingly positive, right? And all of them, appear to be, obvious, right? But there seems to be greater benefit in the younger than the older. My guess is, knowing what we know about the infectious rates here, is that's not due to it not being effective, but death is also going to be an event here in our progression-free survival assessments. They go on to state that new onset infections of grade 3 or higher after 6 months coincided with transition to a monthly drug dosing. So once you got away from that higher dose, at 3 mg per kg every 2 weeks, the infectious rates went down. You have to kind of wonder, do we need that more intense tech dosing? That's how they did in the study. So if you adopt this, once the FDA approval comes for this, that's kind of what we'll do, I would guess. But, it does raise some questions about the risk of this versus the benefit. I'll point out, you can kind of see this in our overall survival curve. You do see the curves cross at this 6 to 9 month mark. You are seeing more people dying on Tec-Dara compared to the comparator group here, mostly Dara-Pomdex. Now, some of that is before they institute the protocol change to look for this hypogammaglobulinemia and be more stringent about IVIG supplementation. And this, I thought, was very well known in the myeloma world, but we have a patient, some years past, who went to a referral center, got CAR-T, and they were not monitoring IVIG levels or IgG levels. We caught that and started it because they kept having recurrent UTIs. So this is something that seems like everyone should know it, but let's just make sure we know it. Let's look at our IgG levels in these folks on BCMA targeting therapy. Okay, so obviously really good, well-designed study. 60% rate of cytokine release syndrome with Tec-Dara, not necessarily surprising. Hypogammaglobulinemia at 85%. Another kind of safety signal here is that secondary primary cancers happen in 12% with Tec-Dara versus 8.6% in Dara-Pom-Dex. So, it's a very effective regimen, but a very toxic regimen. And so one thing, you go down, you fast forward several months or whatever, and this is approved and it's in the guidelines and things like that. I think you got to really judge and assess your patients well for their ability to tolerate what they're going to need to do as far as monitoring, as far as prophylactic antimicrobials to prevent some of these infections. Now, some of this happened during the COVID pandemic. They talk about that in the supplement. Some of these deaths were from COVID, but there's clearly like 25% of these, a quarter of these people had pneumonia. So that's a potentially life-threatening infection. And so those infectious risks are definitely going to show up, and I would expect they're going to show up at perhaps a greater incidence in a regular community versus kind of the structured aspect of a randomized controlled clinical trial. In fact, in a structured environment of a randomized controlled clinical trial, they had to change the structure because of so many infectious complications and infectious deaths. So worth noting, I think this is Janssen who makes these drugs. They had this fixed-dose Teclistamab. I'm sure they had dreams of a combo Teclistamab Daratumumab hyaluronidase product, but that looked to be too toxic. Okay, so moving on. All right, so I mentioned the Teclisto study and some of the smaller studies looking at modifying our dose of Teclistamab. Things again to watch in the future to support that practice. We'll talk more about dosing in a coming abstract too. All right, next is Paradigm. All right, this was probably the more talked about study on social media. This was an investigator-initiated study. Amir Fathi was the presenting author. Kudos on this. It's a good question to ask. And this is HMA Ven, hypomethylating agent and venetoclax, versus intensive chemo in newly diagnosed AML that are fit. These are folks, you look at them, look at the eyeball test, they could tolerate 7+3 or CPX-351, the liposomal formulation of daunorubicin and cytarabine. So this was a phase 2 study. About 180 people in this study, about 70, 80 people in each arm, and they're randomized 1-to-1 to either HMA Ven or intensive chemo, which could be 7+3 or CPX-351. Is about 50-50. I think about 55% got 7+3, 45% CPX-351. This has not been published, so I'm basing what I'm saying here off of seeing screenshots, reading the abstract, seeing screenshots from the presentation, as well as our friends at Wolfram Happy Hour have done an excellent 50, 60, 70 minutes talking about this in much more depth than I will get into. Primary endpoint here is event-free survival, which is defined as progression of disease, persistent disease prompting therapy change, which sounds a little subjective, relapse, hospice, or death. Now, I really want to focus on persistent disease prompting therapy change. Two things that I think immediately stand out to me about this study design, and people saying that, people have talked about there's no more need for intensive chemotherapy, 7+3, we're not going to use that anymore. That's not true. One, it's a phase 2 study, right? We'll talk about the fallacy of changing practice off phase 2 studies. You can bite yourself there. The other thing here is the way the design of the study was. If you were randomized to intensive chemo, you had a bone marrow on day 14, day 13 to 16, okay? If you were randomized to HMA Ven, you had a bone marrow days 21 to 31. Now, this has not been published, so we don't know when these bone marrows were done. We don't know what the events were that led to the event-free survival data, right? Was it death? Was it progressive disease? Was it change in treatment? And that's notable because you're looking for lack of response to treatment much earlier in the intensive chemo than you are with HMA Ven. And if you look at the event-free survival Kaplan-Meier curve, man, it looks like just being randomized to 7+3 is a poor prognostic factor. That EFS curve looks like a waterfall. They are dropping right away. It's like 40% of the people have an event within a month, it looks like, maybe even less than that, which makes you wonder. The first thing is, do we have as a phase 2 study, we got smaller numbers here. Most of these folks were poor risk. was there an imbalance, and there were poor risk on the intensive chemo versus HMA Ven? Would have to probably see all the subgroups for that, and maybe you can't even tell that just because it's a smaller study. Or are you looking at the bone marrow right away, and there's a lot of variability in practice. And these are folks, they gave them, intensive chemo, and you say their bone marrow is 80%. Day 14, it's 40%. Some would change treatment then. Some would say, all right, let's do another bone marrow in a week or 2 weeks and see where we are. And so maybe they change treatment then. You're not seeing, huge, one of the problems here when you look at overall survival, one, it's a phase 2 study. 2 is so many things. Your post-protocol therapy, are you getting HiDAC? Are you doing HMA Ven? Are you getting a transplant? All those things are going to affect your overall survival here. The response rate was 88% with HMA Ven versus 62% with intensive chemo, which seems low, although, again, most of these folks were poor risk. Going to transplant was 61% on HMA Ven and 40% with intensive chemo. If these are mostly, poor risk patients, you're probably not carrying them with chemo alone, right? Even their intermediate risk folks, they're probably going to transplant. So really, if our goal is to get folks to transplant, HMA Ven looks like it makes sense. And we kind of already were thinking that. So I don't know that this really changes practice so much as kind of confirms what a lot of people were already thinking and moving towards. But I think a great question. So many studies these days don't ask the right question, because the question that the studies are asking is, should you buy our drug? Versus, is this, the way that we're treating patients, is there a better way? And this is asking, is there a better way? Is there a safer way? And there's a lot of, positive data trending towards HMA Ven for more folks. Now, these are not your core binding factor leukemia patients. These are not NPM1 positive, younger patients, of course. So this is, a sizable part of the AML patient population. So really, really interesting to see the publication and read the publication with my own eyes before, really talk about, changing what current practices are. Okay, next study I want to talk about is this is a smaller study, and it's a retrospective study, but it's a drug dosing study, or sort of. So this is an analysis of the efficacy and safety of Denosumab in patients with myeloma with severe renal impairment. This is an international myeloma working group bone subcommittee study. How do I get on the bone subcommittee? I guess I got to be an IMWG member first. All right. First, background, Prolia, which is the brand name of Denosumab for osteoporosis. The dosing of Prolia is 60 every 6 months. Okay, 60 milligrams every 6 months. There's a boxed warning on Prolia on the label for Prolia in patients with creatinine clearance or EGFR less than 30 mils per minute because of a risk of hypocalcemia. There is not one on the Xgeva label, which is the cancer bone mets, bone modifying therapy label. That's 120 milligrams every month, much more drug. There's a warning precaution about giving the drug in people with bad renal function. And of course, many of our myeloma patients have this from their myeloma or from older age. So this is looking at what happens to these folks. Now, there are 118 patients. 85 are getting the labeled dose of Denosumab 120 monthly. 17 are going off label, going rogue, and they're getting 60 monthly, lower dose. And what we see in our outcomes, again, retrospective study, what can you tell? Maybe not a whole lot. But I do feel pretty confident they can figure out what drug was given, right? It's not like doing a retrospective study looking at home meds, okay, from like the med list and the EHR, which are never accurate. But yeah, we know what drug was given. That's objective. And what we do see here is that there's much, much more hypocalcemia in the 120 versus the 60. There were 34% of people had grade 3 hypocalcemia with this, and this is known. We already know that this is a risk of hypocalcemia if you're doing Denosumab here. That's a calcium corrected calcium of less than 7. 6% had grade 4. That's a corrected calcium of less than 6, or grade 4. So we already knew this. When this data came out that Denosumab, there was a concern years and years ago that maybe Denosumab had a negative impact on myeloma treatment. Once that went away and people were like, oh, Denosumab, it's great. We can use it in myeloma, especially in the people who have bad kidneys. It's never been studied in people with bad kidneys because we know of this known risk of hypocalcemia in folks with poor renal function. So now looks like maybe we need to dose reduce that. Again, only 17 people got 60 Denosumab, but first do no harm, right? So I think I saw someone say this is something they're going to take back in institute right away in clinic. It's just 17 people, but I think from a supportive care standpoint, it makes sense to try the 60, and if they do okay, maybe you go to 120 afterwards. But I think that's certainly reasonable based on this this abstract that look to be published hopefully sometime soon. So that's worth noting, especially for pharmacists in myeloma clinics doing a lot of work with bone modifying therapy, making sure they're on calcium, vitamin D, all that good stuff. Now the next and the last abstract is one that is a little bit of a thinker and not one that's potentially practice changing right away. But this is interesting. It's looking at Trilaciclib, which is a CDK4/6 inhibitor, but it's an IV. It's actually approved to prevent myelosuppression with chemotherapy in people with extensive stage small cell lung cancer. And they're looking at, by giving this a CDK4/6 inhibitor, can you basically prevent therapy-related changes to hematopoietic stem cells in the form of TP53 mutated clonal hematopoiesis. So this is from like a chip, clonal hematopoiesis of uncertain prognosis. They're looking at that. That's what they're looking at in this research group. And they're like, let's give Trilaciclib to some folks who they look at some healthy controls. They look at people who got chemo on Trilaciclib, and they have blood samples before and after treatment. And basically what they find is if you're getting Trilaciclib, that there's a lower rate of clonal hematopoiesis with CD53 mutations. And so there are going to be future studies thinking, can we give this drug to prevent therapy-related changes? And you could imagine before folks getting bone marrow transplant or intensive chemotherapy that maybe perhaps this can decrease that risk down the line of secondary leukemias. That's really exciting if we might be able to do that. Now, this is very, very early days. And this is a drug, Trilaciclib. There was a breast cancer study where Trilaciclib was given and it decreased myelosuppression, but there was also a trend of overall survival improvement. And the thought was, maybe because if you are preventing, you give intensive chemotherapy, you damage DNA, smart cells with competent TP53, you say, there's too much damage to this DNA, it's not safe for this cell to survive, we got to do apoptosis. Well, if you give chemotherapy and you cause TP53 mutations from the chemotherapy, the cells don't die, and you could have some chemo resistance from that, as well as the secondary leukemias that may happen from this. So this was specifically looking at hematopoietic progenitor cells, not looking at the tumor cells as well. But anyway, so there was actually this Trilaciclib in breast cancer study with gemcitabine and carboplatin that had an overall survival benefit, looked like in a phase 2. The phase 3 read out last year. There was no benefit. So still very early days here, but something interesting that I will be on the lookout for seeing more research publications about this. But interesting stuff there with Trilaciclib decreasing TP53 clonal hematopoiesis in these patients. Okay, so that's kind of what was, and there was a lot of CLL stuff at ASH, but nothing I think really groundbreaking, just some tweaks here and there. Anyway, so that's what I have for you this week. Thank you so much for listening. You can follow me on social media at OncoPharmPod and Pharmdetenib on X. And until I talk to you again, remember, doses matter.